Good afternoon, everyone. We are going to start the next session, that is UKSOS sessions. We have some interesting talks by eminent ophthalmologists. First of all, I'd like to invite Dr. Sanjeev Mittal. तुम्हारी पहले टॉक है ना संजीव तुम्हारी टॉक पहले है ना चलो जाओ क्या टॉपिक है So Dr. Sanjeev Mittal will be speaking on bridging the divide, the ophthalmic and psychiatric disorders. So we have a mix of ophthalmology and some general topics.
Good afternoon. My topic is bridging the divide, the ophthalmic and psychiatric disorders. I would be discussing about the psychiatric problems in patients suffering from ophthalmic diseases and ophthalmic manifestations of psychiatric disorders and antipsychotic and drugs. Why are we interested for the psychiatric problems to look into it in patients who are suffering from ophthalmic diseases? Because the visual disorders will impact the vision, and this will in fact have an impact on the social impact and emotional toll on the patient, and thus it will lead to poor compliance to drug intake, and patient may develop depression. Sorry, some of the contents are not visible in this screen. Epidemiological studies been done at various places, and the various eye diseases like dry eye disease, glaucoma, ARMD, diabetic retinopathy, cataract, and uveitis all have been said to have leading to some depression and anxiety in almost 1/4 of the patients. So this diminution of vision, dry eye, Graves' ophthalmopathy, post-operative patients, and glaucoma, they all may lead to some psychiatric disorders. Visual diminution of vision is one of the important cause leading depression, anxiety, and social withdrawal. Dry eye, allergic, and chronic conjunctivitis, they all may lead in some patients to sleep disorders, anxiety, depression, and mood disturbances. This all lead to low quality of life index in dry eye disease. Similarly, Graves' ophthalmopathy, when the patient meets with the disfigurement and there is a diplopia, again this is a sort of anger in the patient, depression, all this leads some changes in the mood of the patient. Alzheimer's disease already been attributed with the glaucoma, like the glaucoma, in fact the reverse is true, that glaucoma leads to associated with Alzheimer's disease, and in fact some hypothesis is that now that Alzheimer's disease is a type of cerebral form of glaucoma. In our post-operative patients, those who are hospitalized for longer duration or where the visual outcome is doubtful, such patients are very vulnerable for stress. And the patients, this is a change in the environment in the hospital, so all these things are related to the patient's anxiety and depression. The patients, those who are undergoing surgery for both eyes, for example, squint, the bilateral occlusion sometimes can lead to black patch delirium. CSCR is also linked with the type A personality. Retinitis pigmentosa, there is a progressive visual loss, and patient knows that by the middle age he or she may lose a vision, and there is a chronic anticipatory grief leading to depression, anxiety in the patient. So this is about the ophthalmological part leading to a psychiatric. Now the psychiatric illnesses also, they can cause some ocular symptoms. So there are several primary psychiatric disorders which produce distinctive ocular symptoms, either through direct neurological pathways, associated autonomic dysregulation, or indirect mechanisms, such as poor self-care and substance misuse. So there is an understanding, by understanding these ocular manifestations, which will enable us to make an early diagnosis and guides the monitoring and facilitating interdisciplinary care between ophthalmology and psychiatry. So the disorders like bipolar disorder during many episodes, patient may have visual hyperacuity, heightened color perception, sensitivity to light, hypersensitivity to light. There may be some retinal vascular changes. Schizophrenia may lead to impaired tracking with poor smooth pursuit. Abnormal saccadic movements have been observed. And such patients may remain undetected for refractive errors, ocular infections. They meet, suppose ocular trauma may remain untreated. So those are the points. Similarly, Wilson's disease, which may be associated with depression or psychosis, and the findings in ophthalmology are well known in the form of KF ring and sunflower cataract. Dementia leading to retinal cell loss, optic nerve head abnormalities, these are all associations. Similarly, autistic spectrum disorders, they may lead difficulties with face processing, oculomotor dysfunction, strabismus, refractive errors, atypical gaze. So besides this, the antipsychotic and antidepressant drugs which are used, they may also have some ocular side effects. And typically antipsychotics, atypical antipsychotics, antidepressants, mood stabilizers, and anxiolytics, they all may lead to several symptoms in the eye like dry eye, mydriasis, photophobia, and so on. We will be coming to them. Some important drugs which are well known are thoradidine and phenothiazine, which are attributed to pigmentary retinopathy if they are given in higher dose and for extended period. Tricyclic antidepressants, and which is attributed with the mydriasis and cycloplegia and dry eye. Trazodone is related to palinopsia like after image sort of effect. Chlorpromazine, if it is given in chronic periods, longer duration in high dose, more than 800 milligram per day, may lead to some pigmentation in the cornea and the lens. Haloperidol given injectable may sometimes lead to oculogyric crisis. The SSRIs, serotonin, SSRIs, fluoxetine, and these are the commoner one nowadays used drugs which are considered safer. So they are safer than tricyclic antidepressant. Similarly, SNRIs, this is serotonin norepinephrine reuptake inhibitors, they may lead to blurred visions. MAIO inhibitors rarely have ocular effects. Lithium is well known in high doses may lead to blurred vision, nystagmus, and decreased tear secretion. Valproate and carbimazepine similarly may lead to nystagmus. And benzodiazepines, which are widely used, normally they are safer, but initially some people, they may give some transient blurring, but which does not persist. So basically, what is the carry-home message? We should integrate psychiatric awareness into ophthalmological care, screen for psychiatric symptoms in ophthalmology patients, and address the surgical anxiety. Facilitate mental health referrals whenever required. And for the psychiatrist, like our psychiatrist colleague, we can just convey them, the patients that they should inquire about symptoms, ocular symptoms in their psychiatric illnesses. If the patient has that should be referred. And the patients who are on longer duration of treatment or higher doses of those drugs, some drugs, should be consulted for ophthalmology. Thank you very much. These are the acknowledgements for our psychiatric colleagues for this topic. Thank you very much.
Dr. Mittal, I have just one query.
Yes.
Sometimes we see the patient, especially in the RK patient we've seen and some of the LASIK patients, if they are on antipsychotic drugs, the blurring of vision, occasionally they get a blurring of vision or some fluctuation may commonly occur in those cases. Any experience on this?
Yeah, actually that's what I mentioned about that. This is basically the drugs, because this is the blood aqueous, some of the drugs that cross blood aqueous barrier. And they are lipophilic drugs. So that is the reason actually they can cause this effect. So ultimately the psychiatrist, if the symptoms are such aggravating the patient, so the patient is bothered for that, so drugs can be changed. Like the antidepressant SSRIs are safer drugs. So nowadays most of the psychiatrists, they give SSRIs, but like for schizophrenia or other things, like suppose lithium is given, so that lithium blood level should be checked.
Right, yeah. Thank you. Any questions? Thank you so much. And we have got the next speaker from Uttarakhand, a very dynamic surgeon and a dynamic person in the UKSOS, Dr. Satanshu Mathur. He is going to speak on the cracking the rock, phaco in heart cataract.
Good afternoon, everybody. So this is a safe chop in heart cataract. There are many techniques tried by many persons. You can choose whatever best to you. So they're showing two techniques. One is the cater chop technique. One is the cater chop technique. This is the cater that I saw in the Philippines. This is the same. We make a cater in the center of the nucleus, and from there we divide the nucleus and do the chopping. So name is the cater chop technique. That's a popular technique. The cater reduces the mass of the nucleus. What are the advantages of cater chop? This cater reduces the mass of the nucleus before fracture. Before we fracture, we make chopping in the center, so mass of the nucleus become less. Then chop enables surgeon to effectively fracture dense nuclear rim which is left behind. Very easy to fracture it because center mass has been already reduced. Sculpt a shallow cater in the center of the nucleus, and then the outer nuclear rim remain intact, so that it is easy to divide. This is a animation. We make a center cater, and then edge of the cater is held with phaco probe. Very high vacuum use, but power is very less because we are not using any power. We are just doing chopping. This time minimize stress on the capsule and granules, and very minimum phaco power use in hard catheter. Hold by the phaco probe the crater of center of the nucleus where you have made the crater, and then divide the nucleus by holding at the margin. And second instrument is chopping. Then it emulsifies small piece in the space created by the crater. So we have to make a crater in the center, chop it without using energy by vacuum only, and then bring in the center and emulsify. This is the crater we are forming in the center. 3 to 4 millimeter crater is formed in the center. 3/4 thickness you can cut by the phaco energy. So very less energy is used in this case because we are making only a small crater in the center only. The rest of the thing is done by chopping. So crater is formed in the center, 3 to 4 millimeter all around. Once the crater is formed, just hold the periphery of the nucleus, high vacuum, low energy, and divide by the chopper. Just holding it on the periphery. So crater is formed. Just hold and cut by the chopper when the rim is formed. Even 2/3 rim if you make thickness, it will be sufficient for chopping. So crater has been formed. Now hold at the edge and cut by the divider. So it removes, and lateral separation is also done simultaneously. Cutting, holding, and separating, lateral separation is also done simultaneously. Even the thickest plate in the center, you can see it is removed. So small pieces are made. Just hold at the high vacuum and the margin and cut it. And lateral separated. So you see there is no central part is remaining there, and you can easily emulsify the cut piece. We are leaving the pieces in the center because it will keep distended the capsule. It will protect the posterior capsule also. So small cuts are made all around, and then easily bring it out in the center, and you can emulsify them, each and every piece. So energy is very less used, only making the crater in the center. Rest of everything is done by the chopping. So this makes your cornea very healthy next day, even the hardest cataract. So it actually permits in the back phacoinstillation or large brown cataract without complications. There is another method where you can also divide nucleus, hard nucleus. This is the cave chop piece. We are making a cave in the nucleus. Is this the tip of the phaco probe that is slightly longer, giving the space. So capsular axis is done. In harder cataract, we try to do the slightly bigger capsular axis. Hydro, everything has been done like any procedure. So now you see the phaco tip is slightly longer, visible outside the tip or the sleeve, and go inside. And by the second instrument, we are pushing the nucleus down, and by the other pushing the nucleus up by the phaco probe. So you go deep, 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 and deep. A cave is made inside it, and then just crack the nucleus. Even the central thick part is cracked by this simple technique. You can remove any type of cataract, soft, medium, large, hard, or very hard cataract by this technique. Central part, thickest part also removed by one cracking. Then again hold, go deep and deep, like a cave inside, deep and deep and deep, and then just cut it by the probe. So this is the good technique we can have by this method. So we can divide the nucleus in many parts. Hold it and divide. The same thing is repeated again. Holding deeply and then divide. So we can now make it for advanced forward. So we have made many small pieces and then emulsify each and every piece. And you can implant the lens in the bag. Okay. Thank you very much.
Excellent, Dr. Sudhanshu. I think.
Our next speaker is Dr. Vinod Arora. The topic is small pupil, big problem. Dr. Vinod Arora is well-known person, national figure.
So, good evening. Small is not always beautiful. Sometimes it may be troublesome, especially in the cataract surgery. And the question comes, what is a small pupil? Is it a 2 mm, it's a 3 mm, it's a 4 mm? What is a small pupil? Pupil, small size related to the surgeon's skill, technique and intraoperative situations, property of iris tissue and pupil. So if you come to the surgeon's skill and technique, then we can use pharmacological agents like tropicamide, cyclopentolate, NSAIDs, viscomydriasis is known to dilate the pupil like Helon, soft-shell technique, disco-whisk. Then we can use the pupil stretching techniques like elastic pupil and rigid pupil. Then we can have sphincterectomy in the case where the pupillary margin is rigid. And of course, in all cases, we have to use low fluidics parameters. And chopping technique is preferred in this case because it uses less energy and restricts manipulation in the pupillary center. Bimanual NEA is again preferred because it makes the things much easier to do. So question comes, what is the problem of small pupil? If it's a non-dilating, poorly dilating pupil poses a significant challenge. It causes reduced surgical space. Because of the small axis, you have less visibility of the peripheral lens. There may be more chances of iris prolapse. There may be retained cortical matter in the peripheral capsular bag, which we can't see. One haptic of the IOL of the capsular bag may be in the bag, other may be the sulcus. There may be increased chances of postoperative inflammation, corneal edema, and CME. So the question comes, what should we do if we get a small pupil? Any eye can have IFS. We have to be very, very sure. It's not just by seeing you can just see. Reduce threshold for using pupillary expansion devices. Release posterior synechia and peripapillary membrane completely if it's there. Intracameral injection of and combination of mediatics and local anesthetics. test and distinguish the elastic from the non-elastic rigid pupil. Unlike non-elastic myotic pupils, the IFS pupil immediately snaps back to its original size following attempts to stretching it. So you have to remember that small pupil and IFIS are totally different thing with a different mechanism. So coming to this is a chart because positive time I'll not go in detail, but a small pupil, first we try mediatrix, so viscodilatation. If it's not dilating, then we see the analysis of pupil adhesion. We proceed with surgery. And it's required we use expansion devices or we stretch or break or expansion devices. Coming to the iris hooks, it requires 0.5 millimeter incision. A mark is preferred if you make it first, then it becomes much easier. Because if you make a corneal incision, it becomes difficult to see where the incision is there. Limbal incisions are preferred. The stopper should be hold the stopper. Utilize the tented portion, over-retraction and symptomatic retraction of the hook is avoided. Don't stretch it too much. When used after a rhexis, use second instrument. In deep set eyes, you have to problem in the removal, you have to take care.
The APX, the loaded
This is
forceps
Asia
are then
papillary
locked
expander.
and placed on the table until needed.
It's a very good device.
Two 19-gauge side port stab incisions are made parallel to the iris plane,
I think the voice is
opposite
clear.
to each other. A cohesive ophthalmic viscosurgical device is
And it's
injected
being soon
to fill
marketed
the
in India too.
anterior chamber and raise the pupil. The APX device is
It's
inserted
much
through
easier
the
to
stab
use.
incision until the pivot
You
is
don't
within
have to go
the
to
incision.
inside the eye,
The
like anything,
terminal
ring or
tips
anything.
are then
No
positioned
manipulation
behind the
inside.
iris sphincter one at a time, and the forceps are slowly released until the APX device fully expands. The same procedure is done on the opposite
If you are
side.
using a ring, you have to
Note
go
that
inside,
no
manipulate
intraocular
it.
manipulations are required
it's
to
not
position
fair in
the
this case.
APX and dilate the pupil.
It's made of nylon. The peripheral
Capsular
size just
excess
1.1 millimeter. You can go
are
inside.
performed in a conventional fashion
From the
by
side
direct
ports.
visualization
You don't
through
require
the
to do
widely
too many
dilated
holes,
pupil.
just 2 holes.
Removal of
That's
the
already you're doing in
APX is
cataract
done
case
using
anyway.
the
This is again a device from iRing. It's from Beaver VC-Tech. Just a small video. It can be easily inserted, easy to use. Only thing, it's little bulky compared to if you do Swain's ring or other ring, Bhattacharya's ring. But it's a good because it's a totally atraumatic and gives a circular pupil. Unlike other devices which gives a hexagonal pupil, you get a perfect circular pupil and provides safety to the iris margin also. So iris margin is well protected and you can do whatever you want. It will be there centered all the time. So it's made of polyurethane, a very soft tissue. You get a good pupillary dilation that's 6.3 millimeter. It's one of the biggest dilatation you can get, and that too is circular, a completely 360-degree engagement. Then coming to the manual ring, it's a 2.2 millimeter incision is required. That means you have to go through the main incision, gentle expansion, and 8 points of contacts are there. It requires a high viscoelasticity you have to use, and you have to use a ring manipulator for using this thing.
This is Dr. Kachikian from the Eye Institute, and what you're seeing here is the early part of a cataract surgery with a small pupil. The device we are placing here is called a Maleuvian
So you can
ring,
use an injector
and we
that
use
makes the
this
life
ring
much
to
easier.
expand the
Otherwise,
pupil
you
to
can also
allow
do
us
with the iris
to access the cataract and remove
with
the
a
lens safely. Each eyelet
Since
of
cube
the
also.
ring holds it out of place so we can do the procedure. As you can see here,
And taking
once
it
we
out
get
is
the
very
last
easy.
eyelet hooked on the
You just
iris,
engage one of the
the
loop
iris
and
is
just
retracted very well.
stretch it out. It
Placing
will
the
be go
Maleuvian
out.
ring in general is minimally traumatic. And
So you got almost
the
a
ring is fairly
rhomboid
easy
site
as
of
well. So it's an excellent solution
pupil, which is
to a
quite
small
good to do
pupil.
any surgery. Then our own BHEX pupillary expander. It's getting very, very popular because of the cost also, and it has some plus point also. It's a third generation Bhattacharya ring, a flexible jointless hexagonal polymer ring, thin with 6.50 and 0.7 millimeter profile in single cell. Now we have got a newer one also, which is a big, strong, which has 6.75 millimeter of pupillary expansion. I think this is for more if you get a rigid pupil.
The B-hex has redefined pupil expansion. Patented uniplanar hexagonal design with notches and flanges. It is 1/10 the thickness of other devices.
It's very
A
flexible.
23 gauge forceps advances the preloaded device from its transparent housing through the incision into the eye. As alternate flanges are tucked under the iris, the notches engage the pupil margin, resulting in an expanded
Just 1
pupil.
minute.
Removal is so much easier than other devices that it can exit even
So these are the various devices. We can use AIOCs, we can use expansion devices. They are coming in the plenty and the cost is not a barrier now. We can get a very cheaper one costing around 1,500 to 2,000. That's going to be very thing and newer things are coming. Thank you very much.
Any questions by the audience? Dr. Arora, actually just tell us something like with your experience, which is more user friendly. Cost wise, B-Hex I think is and then the hooks are the cheaper, but I think, but which is more user friendly?
For residents or the beginner, I'll say they should start with the iris hook. That is easiest, don't require learning. Only thing we have to follow some of the tips while using iris hooks. Otherwise, they are the much easier. Once you get feel of that one, then it becomes easier to switch over to any expansion device. So if cost is not a factor, then manual is a very good one. If your cost is a factor, I think Bhattacharya ring is well tried and very well you can use it. And of course, we are getting newer devices. Gupta ring is also available, which is little bulky, but can be used.
Thank you. Now with that, we invite our next speaker, Dr. Sunil Chaturvedi. He is a professor and head in Government Medical College, Haridwar. His topic is Liftigrast 5% ophthalmic solution. Is it a game changer in the management of DED?
Good evening, friends. Liftigrast 5% ophthalmic solution. Is it a game changer in the management? Now, dry eye disease causes irritation in eyes and lack of tear film homeostasis. If the symptoms of DED, such as irritation, dry eye, burning, and blurred vision, are left unmanaged, they affect the quality of life and may lead to complications that become long-term. The key part of the DED pathophysiology includes inflammation of the ocular surface, dysfunction of lacrimal glands, as well as instability of the tear film. Lubricating eye drops, corticosteroids, cyclosporin A, and later immunomodulatory agents are the treatment options. These treatments can help to mitigate some of the symptoms, but the underlying inflammation is rarely treated. Liftigrast 5% is a relatively recent approved option for treatment. This is an integrin antagonist that inhibits LFA1 on T lymphocytes to ICAM1. By inhibiting this interaction, it reduces the activation and migration of inflammatory cells, which are thought to be involved in the pathophysiology. Several clinical studies have shown that Liftigrast has shown to be safe and effective in reducing symptoms and increasing tear production in patients with moderate to severe dry eye disease. Unlike the other DED treatments, Liftigrast's action is at the cellular level, targeting inflammation. Now, the effectivity of traditional therapies, for instance, cyclosporin A, is restricted since these inhibit the inflammatory processes through suppression of T cells. There is some efficacy of Liftigrast in symptoms and tear production also, but its effect in real-world settings are not known with respect to long-term outcomes and quality of life. The efficacy and safety of Liftigrast 5% solution for improving DED symptoms, tear production, side effects, and quality of life are tested in this systematic review. The objective of the review is to assess the agent to the extent to which lifitegrast is a significant breakthrough in DED therapy. A search strategy was developed to search for studies on the use of lifitegrast 5%. Several electronic databases such as PubMed, Scopus, Web of Science, and Cochrane Library were searched, and over a period of 10 years, articles published were researched. The studies were subjected to certain criteria so that the evidence in this systemic review is important and relevant. And the population of interest was adults aged 18 years and older with DED. Only those studies that evaluated at least one of the primary outcomes like symptom improvement, increase in tear film or quality, mild to severe side effects, and quality of life were considered. The key findings summarize the results from 10 studies evaluating the efficacy. Across these studies, lifitegrast demonstrated various degrees of symptoms improvement, with most studies reporting significant improvement in the symptomatology. Tear production showed significant increases in several studies, with a few reporting moderate increases. These are the studies right from 2014 to 2024 that have been taken. And in most studies, lifitegrast improved the symptoms in majority. Its efficacy in treating was shown in 7 studies with substantial relief from DED symptoms, including reduced dryness, irritation, and discomfort. The improvements were similar across all follow-up times from 4 to 6 months, suggesting the possibility of achieving short and term symptom relief. 6 out of 10 studies reviewed had significant increase in volume and tear production. Thus, it is effective at increasing tear volume to improve lubrication and reduce the symptoms. Is a potential treatment that does not simplify manage inflammation, but also promotes better production, allowing patients with dry eye disease to get better symptom relief and ocular comfort. All studies do not have consistent evaluation on the quality of life. Eye discomfort and ability to perform daily activities were particularly improved. Now, most of the adverse effects from lifitegrast 5% solution were mild and transient, and no adverse events led to the treatment discontinuation. These included mild headaches, eye irritation, and burning sensation, which was reported the most. The studies had follow-up duration from 4 weeks to 4 to 6 months. Longer follow-up period studies often showed sustained beneficial effect that lasted the duration of symptoms and also meant increased tear production. The purpose of this systemic review was to determine the efficacy and safety. The review was conducted to summarize studies for over a period of 10 years. And this review showed that lifitegrast 5% solution is effective in reducing symptomatology, increasing tear production, and improving the quality of life to some extent. Its favorable safety and efficacy profile for treating both symptoms and inflammation make it an important treatment option. Appears promising for the treatment of moderate to severe dry eye disease to assist in relieving symptoms and increasing production with minor side effects. In future, multicentric long-term or randomized controlled trials are required for better evaluation to understand the scope of its impact on patients' well-being through assessment of impact of lifitegrast on quality of life is needed. Finally, the long-term safety profile of lifitegrast needs to be studied more in depth to to determine the potential ocular complications that will be critical for lifitegrast to continue to be used in daily clinical practice. It appears to be a good treatment option, providing relief. Its safety profile is favorable, milder transitory side effects, and alleviating the symptoms by significantly reducing the symptoms of dryness, discomfort, and irritation. No financial interest is involved. These are my references. Thank you.
Thank you, Dr. Sunil Chaturvedi. Lifitegrast is certainly a good.
Dr. Gaurav?
Dr. Gaurav, meanwhile, please take over. So this is something like a good drug being used. Thank you very much. If anyone has any question, can ask. Please.
Just one query. You showed that there is out of 10, 6 studies shows the benefit, and 4 were not showing any benefit. Or please on the mic. Yeah. Mild benefit. 6 studies show the good benefit with this one. And do you think it should be given in the combination, or it should be given separate? Combination with other lubricants.
Gaurav Luthra's topic is Cyborg, perfecting ICL outcome using AI and deep learning. So this is a mixture of data science with the AI. Dr. Gaurav Luthra, everyone knows, please.
Thank you, sir. Thank you, and very good evening to everyone. So, I wanted to speak on what's new with ICL sizing using artificial intelligence and deep learning models. And I have no financial interest. Phakic lenses have been in use for very long, but sulcus fixated phakic lenses came about somewhere in 2005 when the FDA approval came for the STAR lens, and we have come a long way since then. And right from the time that we started implanting ICLs, probably the most important variable was the vault to be predictable, because that was the key to success with the ICLs. And even 25 years ahead, like, we still don't have a perfect answer, but a lot of research has been done in the last 2-3 years, and I'll be happy to share what I've learned since then. The main difference that is there now is that we have excellent new imaging devices, which includes very high quality anterior segment OCTs, and also with the newer UBM. So I'll be sharing some of those with you. If we could look back in December 2005, Star Surgical got FDA approval for the Vision ICL, and that time the lens size was calculated by adding 1.1 millimeters to the horizontal white to white, and this was the white to white was measured either using the op scan or using a digital calipers, and it was fairly simple that once you had the size, you could just add about 1.1, and there was a Star nomogram which was utilized, and that could give you the size that could be implanted. Later on, we started using Pentacam, because Pentacam white to white was pretty much consistent with the digital calipers, and difference of only 0.1 was seen between what the Pentacam objectively measured and what we got on the digital calipers. So it became easier to use the Pentacam measurements, and then once you put it into the STAR calculator, it will give you a size and the model that can be used. But of course, it was not possible to predict the vault, or how much what was the expected vault, which is now possible with newer systems. So once you have a vault, you can measure it on the OCT, or you can measure it on the slit lamp, and that's decided basically that the difference between the vault and the anterior capsule of the lens. And why ICL sizing is critical is because it decides not only the vault but also the anterior chamber angle, which is very important, because angle must remain open to a bare minimum at least to prevent angle closure. And also, if you don't have a good vault, the stability of the ICL will not be good, and a toric ICL can rotate, and the whole purpose of doing a refractive surgery is lost. So once the Centraflow ICL was introduced, the ideal vault range actually changed, and now Mark Packer in 2016 suggested that you can have a vault between 250 to 750 microns as ideal or tolerable, and even as little as 90 microns to 1000 microns can be in certain cases acceptable. Very high vaults can cause narrow angles and pigment dispersion and pupillary blocks, whereas very low vaults can lead to a cataract formation, or with toric ICLs it can lead to misalignment. So since we did not have a perfect science with the star calculator and with the white to white measurements and the AC depth, a lot of new techniques were suggested over the last 5-7 years. It was suggested that we can use sulcus to sulcus measurements with the UBM, on which a lot of work was done by Dan Reinstein, and then you can also have angle to angle or scleral spur to scleral spur measurements with the OCT, and those can also be used as surrogate anatomical landmarks. And several new OCTs came about, like the Anterion, the Cassia, and a few others as well, which can measure the distances objectively. So these are the few things that you can measure, and there are several variables that can be measured with the anti-segment OCT. And this is, as you can see, in the pink line is the lens vault, and in the yellowish line is the crystalline lens rise. These are again measurements which can be very easily done with the OCT and with the UBM as well. A few studies came about in the last 5 years, which all started using various OCTs. This one was the Nakamura NK formula, which was working on the Cassia AS OCT for vault prediction and ICL sizing. This is the Lasso formula, which came about from Rokamura's team. And again, this was very useful because it could use ALMaster 700, or it could even use the anterior segment OCT for doing vault prediction and ICL sizing. It's freely available online in case anybody wants to use it. It uses, I think, also from the MS39 from the CSO. And a third one came about from Kim, which is based on the Anterion. We started using this formula because we have an Anterion, and we started using this for ICL sizing and vault prediction. Subsequently, another study was being done by Damien Gatinel and Alain Sard out of France on the Anterion, and we were part of that study, and we were a beta testing site for that nomogram. So this is of course from the UBM, and these are some of the things. This is from the Kim's formula. So if you notice the Kim's formula, it gives you a predicted vault and a predicted size. So it's telling us that you can use a size of 12.6 and you are likely to get a vault of 570. It also tells you that if you use a bigger size like a 13.2, you will probably get a vault of about 740. And if you use one size smaller, you will get a vault of just about 428. So then you can basically choose what kind of size and what kind of vault you would like to implant. This is the other new nomogram, which is also available on the Anterion now, and this is known as the Safe Vault ICL. So I was happy to be working with Damien Gatnell and SARS group, and we provided them data of 25 patients from our Indian subgroup, and with that we found a very good consistency. Basically, this data is put into a deep learning based model, and they import the images from the Anterion to suggest this. So it is available again freely online for those people who have an Anterion, and I will not go into the details, but again it tells you for the 4 sizes of the star ICL which are available, what is the likely vault that you're going to get with each size, and you can choose which size you want to implant, and they are pretty close to what actually you finally get. So this is making life much easier for people who do ICLs. So in our practice now, we are using vault prediction using various methods, including the Lasso and the Safe Vault ICL methods from the Anterion. But recently, we also started using the ICL Guru, which is a high frequency UBM. And we were lucky to get the first ICL Guru in the country just about a month back. And these are early days. So let me just take you to the ICL Guru. So this is basically a UBM based method which is beyond the Anterion, because the UBM can actually measure the sulcus. Problem with the old UBMs was that there was no objectivity to the measurement. So essentially what the ICL Guru can do is it does eye tracking, and as you are taking the measurements, it will find out whether you are in the perfect plane and the perfect axis. And once you are in that plane, it also keeps telling you and predicting whether you need to move to the left or the right, or how to center the measurement. And once you are in the green zone, it automatically captures data from the lens thickness and the sulcus measurements and everything, and including the AC depth. So once you have 5 consistent measurements, which generally takes only about 10-15 seconds, it immediately then uploads the images to, it automatically captures and uploads the good images to a server in based out of South America. And so this is the ICL Guru interface, where there is a data transfer which takes only few seconds, and then using artificial intelligence, it will do a measurement and come out with a report, and all this happens in just about 30 seconds. So this is how I'm doing the ICL Guru over here, and it's fairly straightforward because you can keep looking at the screen and making sure that your alignment is correct. This was from the time that we were getting a demo about 15-20 days back. After that, we've used it for 5 patients and found it to give us good results. So this is the kind of report which comes out. It essentially will tell you not only that what size and what vault prediction to get. So it's telling us that if we use a 12.1, we'll get a vault which is almost 0. If we use a 12.6, we'll get a vault of about 300. If we use a 13.2, we'll get a vault of about 700. And this green zone is where you want your vault to be. And if we use a bigger size, we'll go into almost 1000 microns, which is not great. And this is the final printout which comes. So again, it tells you the 4 sizes. But not only does it tell you vault prediction, it also tells you about the stability of the lens. So it will tell you whether your lens, if it's a toric ICL, whether it will remain stable in the sulcus or not. So you can see that this is stability is very high. And you can choose the size based on your thing. So we've used this only for about 5 patients so far and found excellent reproducibility, and it's given us good outcomes. So it also gives us the safety vault bands over here and the stability. So this is something new, and we found it to be very useful. So we are now using both the anti-segment OCT and the UBM to predict vaults, and we are getting better and better outcomes, and almost 100% cases continue to get. So I think we've come a long way, and almost 25 years since we started using phakic lenses, and for the first 20 years we had only one way of measuring ICL. So occasionally you would get a surprise, either you would get a very high vault or a very low vault, and the only choice was to actually change the ICL. But now newer designs are available, so the tolerance for low and high vaults has improved, and साथ में we have now newer imaging modalities which are really helping us. And the deep learning and AI models are really changing life, just like they're changing for us, like with ChatGPT and everything. We are finding things to improve so much, and here deep learning is actually making a lot of difference in how we do measure our patients and position them. So I think it's a good time for those who have not started phakic lenses yet to start it, because now we have more than 95% success rates in vault prediction and with the newer nomograms. So I think with that I would like to finish. Thank you.
Thank you, Dr. Gaurav.
I
Is
think
there
we-
any question?
Yeah, I think Dr. Gaurav has very well pointed out. Basically, what was happening earlier, the gray area in ICL is the white market sizing of the ICL, because we are not directly measuring it. We are measuring white to white and putting the ICL in the sulcus. So we are assuming the sulcus will follow the same ratio. Sometimes we get a surprise. Most of the time it worked well. Dr. Gaurav has implanted a lot. I have implanted a lot. It's working well. But sometimes you get a surprise. It may not be always 1 millimeter more than the what you get white to white. So actually measuring it with the earlier UBM was not very convenient, and it was operator dependent, and we were getting variable results. But I think with this, we are going to much closer to what we actually have to measure. Thank you, Dr. Gaurav.
We invite the next speaker, Dr. Vishal Sharma. Dr. Vishal Sharma is a practicing oculoplastic surgeon in Dehradun, and his topic is frontalis flap technique in congenital ptosis.
Good afternoon, everyone. At the outset, I would like to thank Uttarakhand Society for giving me an opportunity to present in this August gathering. Ptosis correction in special situations is my updated topic, which would include a frontalis flap technique as well as the tarsal switch technique. Ptosis correction surgeries are very demanding, not only in terms of aesthetic enhancement, but also in terms of maintaining functional integrity of the eye. These are my associations. There are various techniques in our armamentarium to correct severe ptosis with poor levator function, such as tarsofrontalis sling with silicon rod being commonly performed, while facial lateral suspension is still considered to be the gold standard. Song and Song had first described frontalis muscle transposition technique in 1982. Frontalis muscle advancement essentially avoids problems related to graft harvesting and synthetic materials being implanted. This procedure avoids the need of a linking structure with the risk of foreign body reaction, granuloma formation, and late exposure, and no need for a second visible incision in the forehead. This is an interesting patient. He graduated in Google and YouTube and presented to me with severe congenital ptosis. He demanded not to use silicone sling. So what I had to do in this case was, he had MRD1 -1, while his levator function was poor. He was able to lift eyelid with above the pupil with frontalis overaction, and also luckily he didn't have amblyopia with his chin elevation. So he went ahead with this frontalis flap technique, and this is at post of one month with a gratifying result. Another case with severe congenital ptosis with chin elevation. She underwent surgery at post-op 1 month. Her pupillary axis was clear and even the head posture corrected. And moreover, with a planned undercorrection, the concern of nocturnal lagophthalmos can be avoided, which was her parents' concern, and they insisted upon the same. This is a case of recurrent ptosis following slippage of silicone sling, was corrected with frontalis flap advancement. Those are surgical steps, marking the crease and local infiltration. Placing traction sutures, followed by skin incision and orbicular dissection. Then you reach up to the supraorbital rim and dissect the frontalis muscle anteriorly, and thus the flap has been created and it's been pulled downwards, and it is attached with the tarsus. So coming to the next scenario, in myogenic ptosis, which can be chronic progressive external ophthalmoplegia, or oropharyngeal muscular dystrophy, or myotonic dystrophies. These are certain situations which are challenging to deal with, as they have poor levator function, as well as the Bell's phenomena is poor, and with oculomotility being limited. Despite doing any conventional procedures, these patients are at high risk of corneal exposure and keratopathy. And thus, the concept of tarsal switch technique came in. In this, we aim to shift the palpebral fissure height, palpebral fissure or aperture superiorly without intending to increase the palpebral fissure height. After marking the skin incision, orbicularis has been dissected. Sorry. Then you mark over the tarsus with the residual tarsus being measured. And then a patch of tarsus, molars, conjunctiva, and a part of aponeurosis. Levator aponeurosis has been dissected and is transposed in the lower lid, while the remaining tissue is attached at the superior aspect of the tarsus. As here you can see, in lower lid, we create a space so that we can graft the graft, so that this graft leads to elevation of the lower lid height. So this is the patient of CPEO, chronic external ophthalmoplegia. Pre-op, you can appreciate the chin elevation as well as the pupillary axis being covered with the eyelid. She was functionally disabled to do her routine work. After surgery, she was able to maintain her head posture in normal position, as well as the pupillary axis was barely clear, so that she can perform her routine activities. As well as there was absence of lagophthalmos in the, which is the important key to prevent keratopathy in such cases. So my take-home message is, every case is different and requires proper assessment and planning. With addition to these two techniques for such special situations, complications can be minimized, with good functional as well as aesthetic outcome. Thank you.
Thank you. Thank you very much. Can we do a fasanal survey in this condition also?
No, sir.
It's not. It will not give a good result.
The thing is not about the good result. It will increase, definitely give result that the papular fissure height will increase, but it will tend to give nocturnal lagophthalmos, what we would want to prevent, because Bell's phenomena is generally poor in such cases, and this may lead to corneal exposure and infection.
That's perfect. Any questions? Thank you. Thank you very much. Close the session.
Yeah, now with this, we close the session of our Uttarakhand Society's session, and we invite all the members of Uttarakhand State Ophthalmic Society to please come on the dais for a group photo. Before, please.
एक यार हमारे कैमरे से ले लो।